treating acute myeloid leukemia with 7 and 3 in 1977. We are still doing the same in 2018. What is the best way forward to change it by 2028?
Well, I think there have been some great amount of progress. Certainly understanding the genetic composition of the leukemic cells has allowed us to stratify therapy. There are some new treatments which are available. FLT3 inhibitors, IDH inhibitors for some subsets of patients. The liposome encapsulated daunorubicin RC seems to be a little bit better for especially poor prognosis patients. But you're right, there's no imminent breakthrough to treat that disease. I think what's going to happen, though, is that some of the newer ideas like antibody-directed chemotherapy and antibody-directed toxins are looking a little bit better and more specific. Whether or not the checkpoint inhibitors could be useful to treat AML, I think is still an open question. But there's a lot of progress that has to be made in that disease. You're correct.
By asking this question, what I'm really alluding to is the fact that most common cancers, as well as the rare disease like AML, are suffering from the same fate, that we have the same slash, poison, burn approach to this day for most of the common cancers.
It's changing. It's changing. I think, as we've, in solid tumors, certainly, the checkpoint inhibitors is a major step forward. Yeah. The common solid tumors.
Second question. There are 3.5 million papers published on cancer. 135,000 in 2017 alone. There's a staggering disconnect between great scientific insights and their translation into improved therapies. What are we doing wrong?
That's a great question. I think a lot of this information is valuable. I think that the problem we have is that there's so much information, and cancer is so complex that it's hard to focus in on the really important things. And as you point out, a lot of these papers are published because people need to publish papers. They need to get grants and they need to keep working. Perhaps, and there are so many journals that take papers which are really trivial. And I don't know how to deal with that, except that the really good journals are publishing things that may lead to breakthroughs in the near future. My own feeling is that we really have to focus on treatments that might help patients, and not so much a lot of trivia that's going on.
Okay, question number 3. The fact that children respond to the same treatment better than adults seems to suggest that the cancer biology is different in the two situations, but also that the host is different. Since most cancer incidence increases with age, even having good therapy may not matter because in the elderly, the host is decrepit. Solution?
Yeah, that's very important. I think most of the childhood tumors are not the same, don't have the same etiology as adult, especially solid tumors. For adults, I think most of them, most adult tumors are a consequence of a series of mutations that accumulate as we get older. And so that leads to a lot of heterogeneity in the tumor. It leads to really difficult treatment, you know, especially if you target one thing or target another thing, because a new clone comes up. And that's why I think some of the new approaches are have a lot more promise than the usual chemotherapy. I think precision medicine is wonderful. We are, in maybe 20% of the time, be able to find something that helps the patient for a while, but it's not curative. I think the great white hope, of course, is CAR T cells. So far, we haven't cracked that barrier yet for solid tumors. It's been pretty much restricted to blood cancers. PD-1 checkpoint inhibitors and other checkpoint inhibitors. I think that's going to be a major way of treating solid tumors. In terms of the pediatric tumors, as I said, they have different etiologies, some viral, some other etiologies. A lot of them are genetic. And I think, as you point out, the hosts are different too. And maybe that plays a role in the responsiveness of those tumors. Yeah.
Thank you. Fourth question, you have great knowledge and experience in this field for several decades. If you were given limitless resources to plan a cure for cancer, what would you do?
I would concentrate in 4 different areas, okay? One, I would try to make CAR T cells better, and that's happening right now. We're understanding what the side effects are. We're making them more specific. We're understanding what patients respond. We don't understand the neurologic effects of CAR T cells yet. If we can harness that power against solid tumors, that's something I would certainly work on. And we actually have a joint project working on that for liver cancer with our chairman of pathology. The second area is the checkpoint inhibitors. I would certainly spend a lot of time and energy understanding why patients respond or don't respond. There is a lot of things going on combining checkpoint inhibitors with other therapies, and I think there's some progress being made there. The third area, which I like, is the antibody-directed toxic chemotherapy. And there's probably 60, 70 approaches to that going on right now. There are only 3 or 4 examples of that working in the clinic. But I think together with some of these other approaches, that's going to be a major area of research. And then something which is receiving a lot of attention now is the microenvironment. A lot of the things we do, we look at cells in culture without the kinds of cells that are in the tumor, you know, the macrophages and the tumor fibroblasts and whatever. And we have to understand a little bit more of how they affect tumor growth and what kind of cytokines and other substances they secrete to make the tumors grow better, and how we can attack that area so that maybe the drugs and the treatments are going to work even better. Those are the 4 areas I would really spend a lot of money on, and that would be my research. kind of agenda.
Great. Last question.
Okay.
Offering patients with advanced stage non-curable cancer palliative but toxic treatments is a service or disservice in the current therapeutic landscape?
That's a tough question, and I think one has to make tough decisions sometimes, and the one aspect is to offer the patient a trial of a phase 1 drug. And if the patient is not willing to maybe be a subject for that, I mean, they have to be very altruistic, because most of the time the phase 1 drugs are going to be too low a dose to help them. Then I think the doctor has to realize that the patient is better off not being subjected to more toxic treatment. And my own feeling is that doctors in taking care of patients privately tend to maybe push drugs a little bit too hard. But it's always a tough decision as to when to stop. It depends upon the conversations with the patient and the family. Yeah.
Well, thank you so much for your time and for your very thoughtful and informative answers. I really appreciate this.
Thank you.
Thank you very much.
As a